Hello, good day. Today, my group will be presenting on the coagulation disorder Haemophilia. The group members consist of Anastasia Harris, Chinelo Izuchukwu, Ron Hilton, Raquel Hartwell, Sarah Lee Gill, and Brianna Henry.
Learning objectives. At the end of our 20 minutes teaching session, the class will be able to define the term hemophilia, identify the risk factors or causes of hemophilia, outline the pathophysiology of the different types of hemophilia, identify the clinical manifestations of hemophilia, outline the diagnostic evaluations conducted to diagnose hemophilia, discuss the various medical and nursing managements of hemophilia, examine the complications associated with hemophilia, and lastly, to outline the health promotions that should be given to individuals with hemophilia.
What is hemophilia? Hemophilia is a congenital bleeding disorder in which the blood does not clot properly due to a lack of clotting factors. This mutation results in the absence of instructions needed to produce the coagulation factors 8 and 9. Types of hemophilia. There are three types of hemophilia. Hemophilia A, which affects 80% of people living with hemophilia, and this is a deficiency in factor 8. Hemophilia B, which affects 20% of people living with hemophilia, and this is a deficiency in factor 9. Acquired hemophilia, which affects less than 1% of people living with hemophilia, and this is an autoimmune disorder which occurs when the immune system attacks healthy cells and tissues.
Risk factors for hemophilia. Gender. Males have a higher risk of inheriting hemophilia due to genetic defects being passed on the X chromosome, which they receive from their mother. Since males have only one X chromosome, they have a 50% chance of receiving the defective gene if their mother is a carrier. Females with two X chromosomes are carriers only if they inherit the mutated gene from their mother or father. This is because one healthy X chromosome can compensate for the faulty one in females. Another risk factor is family history. Due to its hereditary nature, hemophilia can persist in families through generations. Genetic counseling during reproductive years can identify many females as carriers of the mutant gene, even if they don't show symptoms. When carriers reproduce without counseling and partner with other carriers, there's a 25% chance their child will have hemophilia and a 50% chance of being a carrier. Pre-existing autoimmune conditions. Acquired hemophilia can develop when the immune system mistakenly attacks the body's own cells, leading to the reproduction of autoantibodies. These autoantibodies can cause liver damage, resulting in the destruction of essential clotting factors like factor 8. Even without a family history of hemophilia or congenital abnormalities in clotting factor levels, individuals with these autoantibodies may experience symptoms of a bleeding disorder.
Hemophilia A, caused by a missense mutation of the F8 gene on the X chromosome, leads to a deficiency or absence of factor 8. Bleeding in hemophilia results from defective fibrin stabilization due to a defect in the activation of the coagulation cascade. When there is tissue damage in the body, whether it is internal or external, exposed collagen fiber leads to the hemostatic process beginning. In hemophilia A, the disruption of the intrinsic pathway leads to decreased fibrin and thrombin production, leading to a failure in secondary hemostasis. Secondary hemostasis is defined as the formation of fibrinogen into fibrin, which ultimately evolves the soft-plated plug into a hard, insoluble fibrin clot. This insoluble fibrin clot will create a more stable resistance against the blood flow, which would stop internal vascular bleeding. The failure of secondary hemostasis due to hemophilia leads to spontaneous internal bleeding, which can be manifested by hemarthrosis, bleeding in the joints, unexplained bleeding, bleeding in internal organs such as the brain and kidney, as well as easy bruising. These instances of spontaneous internal bleeding in the organs, tissues, and joint spaces is due to the absence of the added vascular protection that the fibrin clot would provide.
Hemophilia B, otherwise called the Christmas disease, happens when there is a deficiency of the clotting factor 9, and it is a X chromosome linked recessive trait that usually affects males more than females. In affected males, there is an extremely low level of the clotting factor 9 without the complete absence of the clotting factor. Females that possesses this trait has 50% of the factor 9 and usually doesn't have bleeding problems. Why is this so? Because only half of the clotting factor is needed in order for clotting to take place. To stabilize the platelet plug, a fibrin mesh must be formed, which needs the activation of two pathways, the intrinsic and extrinsic pathway. Collagen basement membrane, activated platelets, and high molecular weight kinogen stimulates the intrinsic pathway, which includes factors 12, 11, 9, and 8. In contrast, tissue factor stimulates extrinsic route, which includes factor 7. Activation of both the extrinsic and intrinsic routes activates the combined pathway, which includes components 10, 5, 2, and 1, and forms a stable fibrin mesh. Hepatocytes produce factor 9, which is part of the intrinsic route. A factor 9 deficit causes a faulty coagulation cascade and inadequate formation of the fibrin mesh. And so, we can appreciate why this disorder leads to spontaneous and excessive post-traumatic bleeding, which particularly takes place in the joints, muscles, and internal organs.
Acquired hemophilia. This occurs when the body forms antibodies that attack one or more blood clotting factors, usually factor 8, thus preventing the blood clotting mechanism from working properly. This absence of blood clotting factor 8 disrupts the intrinsic pathway, leading to spontaneous internal bleeding in vital organs like the brain, the liver, in between the joints, gastrointestinal system, as well as the renal system.
Clinical manifestations of hemophilia. We have classified our manifestations into objective and subjective findings. Objective manifestations are as such: epistaxis, otherwise known as nose bleeding, ecchymosis and subcutaneous hematoma, uncontrollable bleeding after dental extractions or even after circumcisions, hemarthrosis, commonly known as bleeding to the joints, hematuria, potential renal failure. This is prolonged bleeding in the kidneys that causes damage and will impair the function of the kidneys. And splenic rupture. This is rare, but spontaneous bleeding in the spleen can occur, leading to potential internal bleeding. Prolonged activated partial thromboplastin time. This usually means that clotting is taking longer than expected.
Subjective data. Firstly, pain in the joints, and this is a result of recurrent joint hemorrhages leading to long-term damage to the joints or fixation of the joints, otherwise known as ankylosis. Secondly, in infants, unexplained irritability, and this can be attributed to spontaneous intracranial bleeding. Since hemophilia leads to the failure of secondary hemostasis, there will be instances or spontaneous bleeding or bleeding after trauma in vital organs like the brain. And since infants may have difficulty explaining pain or weakness, they may express their discomfort through increased irritability. Thirdly, brain bleeding once again, causing symptoms like lethargy, paralysis, seizure, headaches, vomiting, sudden weakness or clumsiness, as well as double vision. Diagnostic evaluation. Firstly, polymerase chain reaction. This is the analysis of DNA containing the factors 8 and 9 gene for the diagnosis of hemophilia A or B, whether in carrier state or in utero. Specialized institutes offers polymerase chain reaction analysis of these two factors. This can be done by chorionic villus sampling at 12 weeks or amniocentesis at 16 weeks. Secondly, complete blood count, and this test measures hemoglobin, red blood cell size, and the count and the numbers of various white blood cells and platelets. In hemophilia patients, the CBC results are typically normal. However, if they experience heavy or prolonged bleeding, their hemoglobin and red blood cell count may be low. Third, activated partial thromboplastin time test, which measures the time it takes for the blood to clot with special reagents like heparin. It assesses factors 8, 9, 11, and 12. The normal range for this test ranges from 30 to 40 seconds. Low levels of these factors result in lower clotting times. Hence, people with hemophilia A or B will experience extended clotting times in this test. 4. Factors assays or clotting factor tests. These are necessary to diagnose bleeding disorders. These tests determine the type and severity of hemophilia, which is crucial for developing an effective treatment plan. In suspicion of hemophilia, factors 8 and 9 levels would be assessed to determine if the client has hemophilia A or B. In diagnosing and classifying hemophilia, the levels of clotting factors in the blood are critical. Hence why hemophilia severity table is used. Normal levels ranges from 50% to 150%, with the average being 100%. In 2021, the International Society on Thrombohemostasis classification revised their guidelines for women and girls with an abnormal hemophilia gene and clotting factor levels of 40% or higher or less than 50%. The following classifications were used. For symptomatic carrier, which is someone with clotting factors of levels 40% or higher, they would have bleeding symptoms, but an asymptomatic carrier would not have bleeding symptoms. For those with abnormal hemophilia gene and clotting factor levels below 40%, they are classified as having mild, moderate, or severe hemophilia depending on their specific clotting factor level. This table here represents how it's classified.
Medical management. The standard way to treat hemophilia is through replacement therapy, which is done by infusing the missing blood clotting factor so that the blood can clot properly. The two main types of clotting factor concentrates available for factor 8 and 9 are plasma-derived factor concentrates and recombinant factor concentrates. Plasma-derived factor concentrates are clotting factor 8 and 9, which are made from human plasma. Plasma donations are pooled together in a pharmaceutical plant, then the plasma is separated into different products. This process is called fractionation. The main products from such sources are albumin to treat burns, immunoglobulin to treat problems of the immune system, factor A to treat hemophilia A, factor 9 to treat hemophilia B. Recombinant genetically engineered factors 8 and 9 are not made from human plasma, but they are made by isolating the genes for factor 8 and 9 through genetic engineering. The gene contains the code which has instruction for the cell on how to make human factors 8 and 9. There are pharmacotherapy treatments that are used to treat hemophilia A and B. Desmopressin is a synthetic drug that is a copy of a natural hormone. Desmopressin is not made from blood, however, it is useful in treating people with mild or moderate hemophilia A. It is of no value for people with severe hemophilia A or any form of hemophilia B. It acts by releasing von Willebrand factor stored in the lining of the blood vessel. Von Willebrand factor is another protein that is important in blood clotting. One of its roles is to transport factor 8 into the bloodstream. Desmopressin can be taken via the intramuscular, intravenous, or inhalation route. Aminocarpuric acid is an oral medication that is useful in treating both hemophilia A and B. This medication helps to hold a clot in place once it has formed. They act by stopping the activity of the enzyme plasmin, which dissolves blood clots. Plasmin does not help form a clot, therefore cannot be used instead of desmopressin. They can be used to hold a clot in place in mucous membranes such as inside the mouth, nose, intestines, and uterus. Paralgin is an analgesic that is used for pain management throughout therapy.
The nursing diagnosis formulated based on the scenario showcased on the previous slide is as followed. Risk for bleeding related to deficiency of clotting factors 8, deficient fibrin levels, and defective secondary hemostasis. Secondly, acute pain related to excessive bleeding and inflammation in joints secondary to hemophilia, as evidenced by the patient's verbalization of burning pain in joints and pain rated as 7 out of 10 on the numeric pain scale. If writing a care plan, an acute pain diagnosis would be the priority diagnosis. Lastly, fatigue related to abnormal bleeding and defective coagulation cascade secondary to hemophilia, as evidenced by verbalization of lack of energy, tiredness, generalized weakness, and joint pain. Some of the nursing management of hemophilia include administering analgesics as ordered. Due to the absence of a fibrin clot and the possibilities of hemarthrosis, excess pain and inflammation of the joints can occur. Therefore, patients with hemophilia should be given analgesics for pain management. If pain is not adequately managed, all other interventions can prove to be futile. Secondly, the patient with hemophilia should be educated on the importance of avoiding certain medications such as NSAIDs, herbs such as garlic, and other substances such as alcohol that increases the likelihood of hemorrhage. These agents interfere with platelet aggregation. This interference with platelet aggregation increases the likelihood of spontaneous bleeding episodes among individuals with hemophilia, since they are already at an increased risk of hemorrhage due to the failure of secondary hemostasis. Thirdly, instruct the client on the importance of using a soft bristle toothbrush. Since hemophilia can result in spontaneous bleeding after mild trauma, the utilization of a soft bristle toothbrush with gentle brushing techniques will reduce the likelihood of trauma on the gum line. This practice will assist in the reduction of trauma during oral care while simultaneously preventing excessive bleeding during oral care. Educate the patient on the use of cold compress for pain relief instead of warm bath or compress. During bleeding episodes, heat should be avoided since it can exacerbate bleeding due to the role of heat in vasodilation. Therefore, cold compress can be utilized since it contributes to vasoconstriction, thus decreasing the blood flow during bleeding episodes.
Complications associated with hemophilia. Ankylosis. This is a significant clinical manifestation of hemophilia which arises from recurrent joint hemorrhage, known as hemarthrosis. Additionally, persistent bleeding in the joints causes chronic inflammation, leading to the damaging of the cartilage in the joints, resulting in permanent joint changes. Anemia. This is a condition characterized by a lower than normal hemoglobin concentration, indicating fewer erythrocytes in circulation and leading to reduced oxygen levels in the body. Anemia can result from hemophilia since this coagulation disorder leads to excessive bleeding even in the presence of minimal trauma. The excessive bleeding in hemophilia leads to the loss of erythrocytes, reducing hemoglobin, and impairing the transport of oxygen and carbon dioxide. Excessive bleeding on head injuries. In individuals with hemophilia, the lack of clotting factors increases the risk of bleeding into the brain following a head injury. Bleeding in or around the brain can be life-threatening or result in permanent nerve damage. Hemorrhage. Due to the lack of clotting factors, people with hemophilia are more susceptible to prolonged and uncontrolled bleeding, which can manifest as hemorrhage. Managing hemorrhage in individuals with hemophilia often involves administering clotting factor replacement therapy to help the blood clot and to control the bleeding.
Some of the health promotional messages that can be conducted with individuals who are diagnosed with hemophilia or have a family history of hemophilia includes genetic counseling. Due to the hereditary nature of hemophilia, it is crucial that persons with a family history of bleeding disorders are referred to genetic counseling. Since hemophilia is an X-linked recessive disorder, females may be carriers of the mutant gene without any clinical manifestations of hemophilia. Therefore, women of reproductive age should be informed of their status as a carrier of mutant gene, since male children will have a 50% chance of inheriting a mutant gene due to them only having one X chromosome. Secondly, develop safe non contact exercise programs to enhance joint stability and functions. Since hemophilia leads to the progressive decline of joint function resulting from hemarthrosis and ankylosis, safe non contact exercise programs will allow the client to improve their joint stability. Lastly, educate the client on the importance of maintaining a safe work and home environment. Creating an environment with little to no hazard, reduced clustering, as well as easy access to normal daily items will reduce the risk of falls or bruising. This less hazardous environment will reduce the instances of trauma, which will ultimately reduce hemorrhaging among patients with hemophilia.
That concludes our presentation. Our references are listed on the slide. Thank you for listening.